Welcome to session on Workshop 2, Systemic Chemotherapy and Oncology 2. We have 5 presentations of full papers in this session. These chairpersons are Dr. Masayuki Kurosaki and Dr. Masafumi Ikeda and Hidekazu Kuroda from Japan. Okay, I'd like to welcome our first speaker to the stage. And titled a prospective study to assess the safety and efficacy of lenvatinib in patients with advanced hepatocellular carcinoma, aiming to maximize its potential in current clinical practice. Dr. Kazufumi Kobayashi from Chiba University, please.
Thank you for the introduction. I'm Kazufumi Kobayashi from Chiba University. It's a great honor to be able to speak to you here. Today, I'd like to talk about a prospective study to assess the safety and efficacy of lenvatinib in patients with advanced hepatocellular carcinoma, aiming to maximize its potential in current clinical practice. Let me start the presentation. The COI is as shown in the slide. As you know, systemic therapy for advanced HCC have been making a remarkable progress. Sequential treatment with several drugs is increasingly becoming a mainstream treatment strategy. This study focused on lenvatinib among these medications. Lenvatinib was found to be non-inferior in overall survival to sorafenib in REFLECT trial, and has been widely used in the treatment for advanced HCC. However, the patient population enrolled in this phase 3 trial doesn't precisely mirror the real-world practice. The REFLECT trial excluded certain patient subsets who had an intrahepatic tumor volume 50% or higher, main portal vein and bile duct invasion, and those with Child-Pugh liver disease. Moreover, lenvatinib has become increasingly used as a second or later line treatment with the advent of combination immunotherapy. What about the safety and efficacy of lenvatinib in real-world clinical practice? The aim of the study was to assess the safety and efficacy of lenvatinib in patient population that would receive treatment with lenvatinib in current real-world practice for advanced HCC. This was a multi-center prospective non-randomized single-arm study at 10 institutions in Japan. The present study included patients with advanced HCC considered for treatment with lenvatinib as first line or second line after atezolizumab plus bevacizumab. We defined the patient with 50% or higher liver occupation, invasion at the main portal vein or obvious bile duct invasion as high burden group. Our primary endpoint was the incidence rate of adverse events. Secondary endpoints were as shown in the slide. We also analyzed the transitional plasma concentration of lenvatinib as exploratory endpoints. Plasma concentration was measured at multiple time points from the initial administration of lenvatinib at day 1, and before the administration of day 8 and 15. Here is the patient enrollment flow. 59 patients received lenvatinib, 47 patients with Child-Pugh A, and 12 patients with Child-Pugh B. This slide shows the patient's characteristics. I'm sorry for the busy slide. Of 47 with Child-Pugh A, 11 patients were classified as high burden group, and 12 patients received lenvatinib as second line after the atezolizumab plus bevacizumab. In the high burden group, proportion of patient with Charity score of 6 was high. In patient with Charity B, 9 patients showed Charity score of 7, and the remaining 3 patients showed score of 8. Here you can see the incidence rates of adverse events. Frequently occurred adverse events were different between Charity A and B. Discontinuation rate due to adverse events were 17.0% in patient with Charity A and 33.3% in patient with Charity B, respectively. Now I'd like to show you the result of prognostic analysis. In patients who received lenvatinib as first-line treatment, median overall survival were 21.6 months in patient with Child-Pugh and 4.1 months in patient with Child-Pugh B, respectively. There's no significant difference between high and low burden group patients with Child-Pugh. This shows the swimmer plot of patient's treatment duration and the best response. The duration of treatment was short in cases treated as the second line in patient with Child-Pugh. In patient with Child-Pugh B, the duration was even shorter, but some patients responded for more than 6 months. This graph means the transition of Child-Pugh score. The horizontal axis shows the Child-Pugh score at the start of the treatment, and the vertical axis shows the proportion of Child-Pugh score at the end of the treatment. In patient with Child-Pugh A, 84.4% remained at Child-Pugh A at the end of the treatment. On the other hand, 41.7% of patients with Child-Pugh B had a score of 9 or higher at the end of the treatment. The rate of transition to subsequent treatment after lenvatinib was low in patients with Child-Pugh B. In this slide, you can see the transition of relative dose intensity calculated at every 4-week interval. LDI was lower and more unstable in patients with Child-Pugh B than those with Child-Pugh A. Of course, I know the influence of a small number of patients with Child-Pugh B. This slide shows the transition of plasma concentration of lenvatinib. Plasma concentration levels increase gradually in patients with Child-Pugh B. We analyze the relationship between the plasma concentration and RDI, dose modification of lenvatinib. Both the plasma concentration on day 8 and day 15 exhibited a negative correlation with the RDI. When dividing the patient into 2 groups based on the median plasma concentration on day 8 and 15, both groups with high plasma concentration had a higher frequency of dose modification. Based on these results, it can be inferred that a decrease in liver function reserve leads to higher plasma concentration, and resulting in reduced RDI and high frequency of dose modification. This is the last slide. Lenvatinib is safety and effective for advanced HCC in patients with Child-Pugh A, even with high tumor burden. However, it carries a high risk of adverse events due to the tendency of higher plasma concentration of lenvatinib and may not provide adequate efficacy for patients with Child-Pugh B. The present study was supported by many collaborators. I'd like to express the greatest appreciation to my coworkers for the excellent cooperation. Thank you for attention.
Thank you, Dr. Kobayashi. Do you have any questions and comments in the floor? Okay, I have one question. You said you study does not strongly recommended lenvatinib for child B grade B. Um, um, how many points of child P score can be treated with lenvatinib? About 7 points. Is okay or not?
Our study clarified that the plasma concentration level of lenvatinib is high in child PUB patients. So we suppose that it's enough for patients with child PUB patients. For example, 4 milligram per day of lenvatinib. So I think it's my opinion at the patient with child abuse class 7. I want to try to 4 milligram per day of lenvatinib.
Okay.
May I ask you one question? Kurosaki. You said that in child PUA, there was 11 or 12 patients with high tumor burden. And your definition of high tumor burden was that the liver tumor volume is over 50% or having the vascular invasion. My question is that the patients who have a vascular invasion, do you have a plasma concentration data of lenvatinib in these patients? My question is whether the presence or absence of a vascular invasion is associated with the plasma concentration of lenvatinib or not.
Thank you for your question. I'm sorry, we don't conduct that kind of analysis, but we define the presence or absence of portal hypertension in these patients. And the patient with portal hypertension showed a higher transition of plasma concentration. So the I think the blood flow is has a relationship to the metabolism of the lenvatinib. So I suppose that I wonder the patient with portal invasion show any influence to the plasma concentration. I'm sorry.
Thank you for your answer. So if the patient has a vascular invasion into the major portal, VP4, it may be possible to affect the concentration of lenvatinib because the blood flow into the liver may be decreased. Thank you.
Thank you so much.
Yeah.
Okay.
よろしいでしょうか。
Okay.
People talking about lousy TKIs, and so the lenvatinib, how it functions with the tumor cells. I mean, very basic question. Sorry about that, but I want to know that. In context that so far there is a failures combination with ICI plus lenvatinib comparing to the AV atezolizumab. So beva is consort of TKI. So without understanding the lenvatinib function on the cancer cells, then maybe that's related to the failures or combinations. やっぱりレンバチがなぜ失敗しちゃったかっていうのは、レンバチがどうやって機能してるかっていうのを、そこのところをちょっと教えていただきたい。今更そんな聞くのもちょっと恐縮ですけど。
レンバチが失敗した。
じゃあ next time ね。次じゃあゆっくり。
I'm sorry. Thank you for your question.
Because nowadays the molecular interaction is very much yesterday, but the TKIs is just the in vitro assays. And you are not really crystallizing the molecules and seeing the sites of the interactions. So that's why people are talking about lousy TKI, and maybe based upon that. So that's my questions. But maybe next time, yes.
Thank you,
for your
Professor Omata.
introduction.
And thank you, Dr. Kobayashi.
Thank you so much.
Okay, we move next speakers. Titled Prognostic Factors of Survival in Patients with Intermediate Stage Unresectable Hepatocellular Carcinoma treated with lenvatinib or atezolizumab and bevacizumab. And Dr. Naoki Uchihara from Musashi no Red Cross Hospital, please.
Thank you, Chairman. Good morning. It's a great honor for me to give a great presentation at this wonderful meeting. Today, I would like to talk about factors for survival in patients with intermediate stage unresectable HCC treated with lenvatinib or atezolizumab plus bevacizumab. This is my disclosure. Recently, the strategies for intermediate HCC have been dynamically changed. Professor Kudo proposed the concept of clinical CR and drug-free violentase or ABC conversion. Even though the recommendation as first-line systemic therapy is immunocombination therapy in the JSH-HCC guideline, there are no established recommendations about relentless or ABC conversion in intermediate stage HCC. The aim of the study is to make therapeutic strategies in intermediate HCC according to the prognostic markers in each therapy. Therefore, we investigated the prognostic factors for survival in patients with intermediate stage HCC who received lenvatinib or atezolizumab plus bevacizumab therapy in real-world practice. In the study, the patients who had BCLC stage B HCC and up to 7 out and received lenvatinib or AB at our hospital were included. The overall survival and progression-free survival were analyzed retrospectively using the Kaplan-Meier method. First, I'd like to show you the results of AB group. This is the baseline characteristics of AB group BCLC-B up to 7 out. AB for the first line treatment was in 38 patients, second line 14, and third line 5 patients. Child PUA patients were 84%, while child PUB was 16%. This graph shows the overall survival of AB group BCLC-B up to 7 out. For all 57 patients, median OS was 21 months. For the 38 first-line patients, median OS was 18 months. Next, we see the PFS of AB group BCLC-B up to 7 out. In all patients, median PFS was 8 months, while in the first-line patients, median PFS was 8 months. Then, this is the result of factors associated with OS of AB group. In the univariate analysis of all patients, baseline RB score and creatinine before treatment were significant factors associated with OS. In the multivariate analysis, creatinine before treatment was a significant independent factors. In the univariate analysis of first-line patients, age and child PUA score were associated with OS. In the multivariate analysis, age was significant independent factors. This slide shows the factors associated with PFS in the univariate analysis of all patients. Significant factors that associated with PFS was urine protein creatinine ratio (UPCR) before treatment. However, when we analyzed the patients who were administered AB as a first-line therapy, there was no significant factors associated with PFS. To summarize OAB, the significant factor associated with OS in multiple analysis was only age in first-line patients. There was no significant factor associated with PFS in first-line patients. Tumor size and number were not associated with OS and PFS. Next, I'd like to move on to the result of lenvatinib group. This is baseline characteristics of len group BCLC-B up to 7 out. Len for the first-line therapy was for 28 patients, second line 7, and third line 9 patients. CHART-PUA patient was 95%. These Kaplan-Meier curves are overall survival in patients of len group. The left panel shows the result of all 44 patients. Median OS was 22 months. For the 28 first-line patients, median OS was 22 months. When we see the PFS of len group, BCLC-B up to 7 out. Median PFS was 6 months in all patients, while median PFS was 7 months in the first-line patients. This is a result of factors associated with OS of len group. In the univariate analysis of all patients, baseline RB score, NLR, and AFP higher than 400 in the multivariate analysis were significantly associated with OS. In the multivariate analysis, baseline RB score and NLR were the independent factors associated with OS. For the first-line patients, baseline RB score was the only significant factor associated with OS in the multivariate analysis. This is a result of factors associated with PFS of len group. In the univariate analysis of all patients, baseline RB score, CRP, NLR, AFP higher than 400, and the number of tumors were significantly associated with PFS. In the multivariate analysis, CRP was only significant factor associated with PFS. For the first-line patients, baseline RB score and CRP were significant factor in the univariate analysis, and both factors remained significant in multivariate analysis. To summarize of lenvatinib, the significant factor associated with OS in multivariate analysis was pretreatment RB score in first-line patients. The significant factors associated with PFS were pretreatment RB score and CRP in first-line patients. Tumor size and number were not associated with OS and PFS. In conclusion, in BCLC stage B and up to 7 out patients, a maximum tumor diameter and number of tumors were not predictors for OS in lenvatinib and atazanavir. Pretreatment RB score and CRP are clinically important in lenvatinib. Thank you for listening.
Thank you for an interesting presentation. Is there any question and comment? The floor. Can I have a question? Okay. Can I have a question? Okay. You said you analyzed prognostic factor for OS, and Dr. Yasui said AFP response and the VEGF response is an important prognostic factor for PFS. What do you think about it in this your intermediate stage study?
Thank you for asking. maybe I think in intermediate stage HCC for AB, sorry,
Dr. Yasui, please.
sorry.
Yasui, one of the co-authors, and I think I don't. Actually, I didn't analyze this data, but I think AFP response is also important for intermediate stage HCC. So, in this study, we analyzed the baseline characteristics to predict OS and PFS and compared patient who received AB or patient who received LEN. So in this study, we didn't analyze the on-treatment response or on-treatment biomarkers. Thank you.
Okay, thank you. Professor, please.
じゃあ日本語でいいですかね。その最初からアップトゥー7とかっていうルールで切り込んでいったら、例えば前の演題はテューマーバードンとあんまり関係ないということですよね。だったらもう全部それシャッフルして、レースを増やして、アップトゥー7もバリデーションするし、それから先の CRP でもよろしいですけど、そういう切り口でやるっていうのは、最初から言っちゃうともうそれでバイアスかかってますんで、アップトゥー7のバリデーションしたらどうでしょうか。
そうです。いや、ご質問ありがとうございます。そうですね。今回のコンセプトとしては、そのインターメディステージのアップトゥー7アウトに限って、治療の効果判定が、その予防因子が何かっていうところを調べさせていただいたというような形になります。
Can I have a comment? I'm Dr. Tsuchiya from his course. The concept of this study is in the real-world clinical setting. The clinical question is, which therapy should we choose, lentase or atezolizumab, especially in the patient with intermediate stage and up to 7 out. So this study focuses on the choice of the therapy. So the Dr. Kuroda asked us the question, the on-treatment biomarkers, but in this study, we focus on the pre-treatment condition because before studying therapy, we don't know the on-treatment reaction. So in this study, we focus on the which therapy should we choose, lentase or atezolizumab. So the conclusion is we can focus on the CRP or AFP or NLR. If we choose the lenvatinib, we focus on the factors, not only the tumor status. Sorry, I have a bad voice.
Okay, I understand. And thank you for your presentation.
Next two presentation chaired by me. I'm Ikeda from National Cancer Center Hospital East. So third presentation is Kodama Sensei from Osaka University. The title of his talk is Immunokinetics Analysis Predicts the Efficacy of Combination Immunotherapy for Advanced HCC. Dr. Kodama Sensei, please start your lecture.
Thanks, Chairman, Professor Ikeda, for the kind introduction. This is a great honor for me to have the opportunity to present my data here today. So today I'm going to talk about the immunokinetic analysis that may be able to predict the efficacy of the combination immunotherapy for the advanced HCC. This is my COI. So first, let me briefly explain the background of my study. So anti-PD-1 and anti-VEGF therapy, so-called atezolizumab for the advanced HCC, became the first-line chemotherapy since 2020. So its response rate is approximately 30%. However, the 20% of the patients, that's showing initial resistance in the clinical trial. And this is a real-world data of the adalimumab therapy for the 85 advanced HCC patient in our Osaka Liver Forum cohort we published last year. And you can see in the center, the response rate is 33%, and 35% of the patient are initially non-responder. However, there is no biomarker to predict the non-responders. So in general, the efficacy of the immune checkpoint inhibitor is affected by the tumor-infiltrated lymphocyte status. We call the immune hot and immune cold, stratified into these three groups. And then in general, the immune hot tumors are more sensitive to the ICI therapy. So we previously performed the RNA sequence and the cancer genome sequencing on more than 100 of the HCC tumors to understand the time in HCC, the resectable HCC, I mean. And then we found that 2/3 of the patient are immune cold phenotypes. However, the time in advanced HCC has not been fully validated. So the aim of my study is to explore the predictor of the therapeutic response and the clinical outcomes upon the adalimumab therapy in advanced HCC through the time analysis and also liquid biopsy. To this end, we performed two experiments. One is a profiling of the tumor microenvironment with RNA sequencing and BZIM of the tumor tissue. And the second part, we profiled the circulating immune cells with a single-cell RNA sequence of the PBMC. So this is a clinical background of the adalimumab-treated HCC patient used for the time study. So 10 from responder and 13 non-responder. And we collected the pre-treatment tumor biopsy and we performed the RNA sequencing. So first, we try to determine the tumor's immune status by looking at the immune signature and also T-cell exhaustion signature from the RNA sequencing data. You can appreciate that the responder has a significantly higher level of immune signature and also T-cell exhaustion signature, suggesting that this immune hot and exhausted phenotypes are prerequisite to get a response from the adalimumab therapy. And also, when we look at the individual gene and the pathway analysis, we found that the responder has a significantly higher level of the interferon-related genes, such as interferon gamma, granzyme B, and CXCL9, and also the variety of the HLA expression. And the pathway levels are activation of the antigen processing and presentation pathway, and also T-cell and B-cell receptor signaling pathways. So next, we try to check the gene expression signatures predicting the ICI outcome in HCC. Several expression signatures are already published, including the interferon antigen presentation signature for the PD-1 inhibitors, and also adalimumab response signature for the adalimumab. So we checked these two signatures, and we found actually the responder has a significantly higher level of the ABR signature and also interferon AP signature. However, only the ABR signature nicely stratified the progression-free survival upon the adalimumab therapy. Then next, we selected 3 non-responder and 3 responder patients and performed the BGM spatial transcriptome analysis. And we collected all these spots and integrated into one big path here, right here. And then we did a clustering analysis, and we found that they're stratified into the 5 different clusters characterized by such as immune cold tumors with malignant immune cold immune cells and also malignant tumors. Also the combination of the immune hot tumors and with fibroblasts and malignancy. So, and then we put back these clusters into each individual patient, and we calculated the number of each spot. And then you can see here, when we compare the non-responder and the responders, responder has a significantly higher number of the spot of this green spot, indicating immune hot and the fibroblast and malignant, suggesting the cross interaction between the tumor cells and the immune cells are important for the response to the adalimumab therapy. Also, we performed the signature analysis using this spatial transcriptome data, and we found that the non-responder tend to have the high level of the MYC target pathways, and on the other hand, the responder shows a higher level of the interferon gamma pathway and also CD8 T-cell exhaustion and the T-cell effector and also CD8 activation. So basically, CD8 T-cell activation is also required for the get response for the adalimumab therapy. And also MYC pathway is related to the resistance to the adalimumab therapy. So next, I'd like to move on to the circulating immune cell part. So in this single-cell RNA sequence cohort, we selected the 5 responder patients and also 5 non-responder patients, and we collected blood from the pre-treatment and also just before the 3 cycles treatment. And we performed the site-seq analysis, which simultaneously performed the single-cell RNA sequence and the single-cell surface protein analysis, as well as the T-cell and B-cell repertoire analysis. So this is a UMAP clustering of the 20 samples, including the 230,000 cells. And we can nicely actually classify into these population into 30 cell clusters based on the representative cell markers. And then we split this patient into the 4 groups: the responder and the pre-treatment, and responder and the post-treatment, and non-responder pre-treatment and post-treatment. And then we compare each individual immune cell frequency among this cohort. And then what we found is a responder has a significantly higher level of the CD4 positive central memory T cells with in the responders, and also the non-responder groups has a significantly higher level of the CD14 positive monocyte. On the other hand, there is no difference of the CD8 T cell frequency between the responders and the non-responders. However, when we look at the detail of the CD8 T cell gene expression, we found that the responder patient have the higher level of the HLA expression and the CR3 expression and the granzyme expression, suggesting the activation of the CD8 T cells. And also, when we performed the pathway analysis, we found the T cell differentiation pathways are significantly activated in the responders. And lastly, we performed the T cell repertoire analysis of a CD4 T cell, and we found the responder have the higher repertoire density and also diversity. So this is a summary of my research. The first part, time profiling, immune hot and exhausted time was associated with better response to the therapy. So basically, the immune hot tumor is a prerequisite for to get the response for the therapy. And the PBMC profiling part, responders show the enrichment of the CD4 positive central memory T cell and also depletion of the CD14 positive monocyte. And the responder displayed the genes associated with the activation or differentiation of the CD8 T cells at pre-treatment, and responders showed higher density and diversity of the CD4 T cell repertoire. So these data suggested, priming phase has to be finished in order to get the nice response to the therapy. So in conclusion, the biomarkers based on the time and liquid biopsy may be helpful to predict the treatment response and the prognosis of the HCC patient who underwent therapy. These are my colleagues and collaborators. Thank you for their help, and thank you for your attention.
Thank you for your beautiful presentation by the fluent English. Any other comment or question from floor? Yes, please.
Yes.
お待たせ。
望月先生、じゃあどうぞ。
I'm Hitoshi Mochizuki, a Genome Analysis Center at Yamanashi Central Hospital. I had researched the transcriptome of HCC and analyzed the immune cell classification. And in this study, I think the tumor heterogeneity is very wide about immune cell. And in your lecture, you told the Visium a very different heterogeneity. So I think the whole body, as whole body, you so the effectiveness or so it's very hard to the word in hot or cold in word for one nodule. I think, how do you think the intertumor heterogeneity of about immune heterogeneity?
Thank you for the very important question. I think it's one of the unique characteristics of HCC is the intratumor and also intertumor molecular heterogeneity. So when we do the bulk sequencing, and we can define the immune status. However, when we look at by the Visium, as you mentioned, that actually some of the spot are the immune hot, but some of the spot are the immune cold. But when we mix together and overall, when we analyze in one piece of the tumor tissues, we can predict the response based on the frequency of the immune hotspot together with tumor cells. So it's still, but it's a problem. I understand that.
I think without these steps, we cannot proceed. So wonderful studies, very expensive, I think. But in terms of the predictabilities, you are trying to elucidate. But if you look at the area of the IO-ICI treatment, huge number of patients treated. But till now, only PD-1 and PD-L1 staining is the only way to predict the responses. So among these studies, what can be the next step to apply this among so many parameters you are studying, which can be the quickest, easiest way to predict the patient's outcome, especially not just in the hepatocellular carcinoma and in other malignancy. And this question can be addressed to Dr. Ikeda Sensei as well, because Ikeda Sensei belongs to the Cancer Institute, and then they are having a huge project undermining the basic things. So in this particular occasion, both of you, I want to ask the questions.
Yeah, thank you for a very important question. I think related to the previous question, because HCC has a heterogeneity, so I think ideally not the tumor biopsy, but the circulating immune cells or circulating markers should be, proceeded to predict the response. So in this point, I think today I showed that especially the ratio between the lymphocyte and monocyte, such as the CD4 T cell and the myeloid cells, I think they're critical to predict the response of the PD-1 therapy. And but the problem is because we can predict the ICI response. However, the Untitled therapy also combined with anti-VEGF therapy. So maybe we also better combine together with immune cell profiling and also together with some of the cytokines, such as mentioned the previous speakers, such as angiogenesis signaling. Maybe when we combine these together, and maybe we can take the blood and we can predict this response in the future. That's what I'm thinking.
Okay, thank you. It's not proper to ask the question to the moderators, but Ikeda Sensei may have
Thank you very much. Thank you very much for your great question. So in our hospital, so clinical practice or clinical trials, a lot of the ongoing, but we have no research fellow, so we cannot go perform to the research analysis even in the HCC area. So that is our big issue for our department. So
but Dr. Tsuchihara Sensei just came to my hospital 2 days ago, and he mentioned the huge project that under the Sendai Kaihatsu Iryoka.
Yeah.
So in your division, you don't have any fellows, but as a whole, the Cancer Institute may have.
We have collaborated with Dr. Tsuchihara, so genome profiling analysis. However, just only genome profiling, so not so further analysis is not done. I'm sorry.
Yeah, but I repeat, without these studies, I think we cannot proceed. Thank you very much.
Thank you. Last question is from Nishida Sensei.
Thank you, Nishida from Kinta University. So I'm interested in the mechanism by which the activation of MYC pathway is correlated with resistance to immune checkpoint inhibitors. Is there any causal relationship or just a correlation?
So the pathway?
Yeah, the MYC pathway. Why the MYC pathway is associated with resistance to immune checkpoint inhibitors?
Yeah, so today I just only show the correlation analysis in the MYC pathway and the non-responders. However, some of the papers address the mechanism of how the MYC pathway, basically MYC pathway causing the immune cold phenotypes and related to the beta-catenin signaling as well. So that's one of the mechanisms I believe that Atazolizumab becomes resistant to the MYC-activated tumors.
Thank you very much for your nice talk. So next speaker is Kuzuya Sensei. Kuzuya Sensei, his talk is about cabozantinib therapy in patient previously treated with atezolizumab. For advanced HCC, importance of good liver function and good performance status. So please start your presentation, Kuzuya-sensei.
Thank you, Chairman. So today I'm going to talk about the cabozantinib therapy in patients previously treated with atezolizumab. So this is CY2 disclose. So first, I show the guideline for HCC in Japan. So as shown here, the systemic therapy algorithm for patients with unresectable HCC. So atezolizumab or durvalumab is recommended as first-line treatment systemic agent. And as for the second-line treatment, so as shown here, all other systemic agents are equally recommended. However, which treatment regimen is effective and safe, it is we don't know. So in this study, so we investigate clinical outcomes for cabozantinib in clinical practice in patient-based advanced HCC previously treated with atezolizumab, and focusing on whether patients met criteria of CHI-2 class A and PS score 0 or 1 at baseline. So in our hospital, so we have a total of 21 cases who started with the cabozantinib. Among them, so 19 patients with a history of atezolizumab were enrolled in the study and evaluated the clinical outcome retrospectively. So this slide shows the baseline characteristics. So as shown here, the median age is 67. And so as for the liver function, CHI-2 class A is in 12 patients. And concerning the general conditions, performance status score 0 or 1 is in 16 patients. So in terms of the previous systemic agents before cabozantinib, as shown here, so in all 19 patients have previously treated with both atezolizumab and lenvatinib. So all patients were introduced cabozantinib as third line or later lines. So regarding the cabozantinib initial dose, 16 patients was started with reduced dose due to the patient condition at baseline. So we compared the efficacy and safety of cabozantinib in patients with and without the CHI-2A and PS01 at baseline. So I'll show the results. This slide shows the best anti-tumor response according to RECIST. As shown here, in all patients, ORR is 5%, and DCR is 50%. And in CHI-2A PS01 group, ORR is 9%, and DCR is 80%. And in non-CBA PS01 group, DCR is 2%. So significantly higher in the CBA PS01 group. So median PFS in all patients is 2.1 months. And as shown here, the PFS in the CBA PS01 group is about 4 months. So it's significantly longer compared to the non-CPI and PS01 group. So we check the baseline factors related to PFS. So as you can see here, the good PFS factors is only the CHI-2A and the PS01 at baseline. So median OS is about 7 months. So OS in the CPA and PS01 group is over 1 year. So significantly longer than the non-CPA and PS01 group. So we also check the baseline factors related to OS. So as shown here, the significant good OS factor were the Child-Pugh-A and PS01, and no PVTT and no extrahepatic metastasis. So let's move on to the safety. So this slide shows the adverse events within the 6 weeks after the cabozantinib initiation. In all patients, the most common adverse events is anorexia, proteinuria, general fatigue, and hand-foot syndrome. So grade 3 in Child-Pugh-A and PS01 group, grade 3 or higher adverse events is general fatigue is the most common. And on the other hand, in non-CPI and PS01 group, so the most common AE is the general fatigue and the anorexia. So I'll show you the changes in the RB scores. As shown here, the RB scores in both groups get worsened over time. So this slide shows the daily dose of cabozantinib within 6 weeks after the start of the cabozantinib. So in all patients, about 20 milligram per day. RDI is about 30%. So as you can see here, the daily dose of cabozantinib in the CPA and the PS01 group is significantly higher than the compared to the non-CPA and PS01 group. This slide shows the duration of cabozantinib therapy. So duration of cabozantinib in the CPA and the PS01 group is significantly longer than compared to the non-CPA and PS01 group. So in conclusion, cabozantinib in patients previously treated with atezolizumab has potential therapeutic efficacy and safety if patients have good liver function, Child-Pugh-A, and in good general condition PS01. That's all. Thank you for your kind attention.
Thank you very much for your nice talk and clear conclusion. Any question from audience? So your recommendation is a Child-Pugh-A, PS01. So if the Child-Pugh-B patients, so you cannot candidate for the cabozantinib treatment? Is it right?
So that's a very good question. So based on our small number the experience, the patients with Child-Pugh-B, the therapeutic efficacy is very poor. So in my opinion, if the alternative agent available in such a cases, so we don't recommend the cabozantinib for patients with Child-Pugh-B.
However, the toxicity profile is very similar between the Child-Pugh-A and non-A. So how do you think about the feasibility of the cabozantinib?
So in my presentation, so in patients with the Child-Pugh-B or the PS2, in such a patient, so the frequency of appetite loss or fatigue is more frequent. So such adverse events can lead to the deterioration of your function.
Okay, thank you very much. Any other question? No? So thank you very much for your great presentation.
So I will invite the last speaker of this session. This is Kurosaki. I would like to chair this session. The presenter is Professor Takahiro Nishio from Kyoto University, and the title of his presentation is The Therapeutic Strategy for Advanced SCC with Combination of Systemic Therapy and Surgical Resection. Please start.
Thank you very much. I greatly appreciate this opportunity to make presentation our topic. Now, recent advances of systemic therapy for advanced ACC, including nebatinib, atezolizumab, and threat regimen, has contributed to the significant improvement of patient survival. And according to guideline of US and Europe, the indication of resection is very limited in the very early stage of ACC, and separate indication from the systemic treatment. On the other hand, in Japanese guideline, the indication resection might be some relatively broad, showing some overlap with systemic therapy, especially particularly in the cases of patients with vascular invasion. And our institute has proposed a potential algorithm of resectability for patients with advanced ACC, and based on the features of oncological, technical, and liver function indicator, successfully stratify the patient survival after hepatectomy, categorized as resectable, borderline resectable, and unresectable. Now, the advances in this systemic therapy may highlight the potential effectiveness of the combination strategy according to this resectability, such as adjuvant therapy, neoadjuvant, and convergent surgery. To optimize the such effectiveness of a combination strategy, it might be important to precisely define the resectability for advanced ACC. Now, challenges of challenging the combination strategy, the effectiveness of lenvatinib after resection has been elucidated by LENS-AC trial, resulting in a resection rate of 67% with relatively good overall survival. Now, rapid trial is ongoing, focusing on the effectiveness of atezolizumab after atezolizumab followed by surgery, specifically focusing on the endpoint of PFS. And recently, the result of IMBRAVE 050 revealed the effectiveness of atezolizumab in the adjuvant setting. Regarding the neoadjuvant trial, now Leopard Neo study trial is now focusing on the effectiveness of lenvatinib plus hike with CDDP, potentially targeting the borderline resectable defined as macrovascular invasion. In this particular era of development of systemic therapy, we aim to assess the real-world efficacy, specifically focusing on the combination strategy of surgery and systemic therapy. 80 patients with lenvatinib and 62 patients with atezolizumab as a first-line systemic therapy or retrospectively analyzed. And in both groups, the non-viral etiology was a majority, accounting for more than half. And major indication include the multifocal up to 7 out like here, and 30% had extrahepatic metastasis, and 30 to 50% of recurrence after hepatectomy, and macrovascular invasion cases accounting for around 10%. And the best overall response, according to modified RECIST, shows the objective response more than 40% and disease control rate more than 80% in both groups. And the adverse effect, grade 3, as shown like here, including the around 10% of immunomediated AE in atezolizumab bevacizumab group. And the patient characteristic show that the lenvatinib group potentially include 16% of child B cases, showing a relative poor liver function reserve. And the proportion of up to 7 out is relatively high in that Weber group, but there are no significant difference among the tumor characteristics, including tumor burden nor tumor markers. Regarding the outcome, there are no difference in overall survival between groups. However, this bevacizumab group shows better PFS with median 15 months, and TGF and duration response was longer in this bever group. And there are no significant difference in outcome according to the etiology, viral or versus non-viral. And responders to lenvatinib show a good survival outcome like here, and similar trends are found in following by the bevacizumab therapy. And what is the factor associated with the response, such a response? And multivariate analysis shows that the pre-treatment F level was associated with the objective response after lenvatinib therapy, and pre-treatment DCP was an Weber. And regarding the overall survivor, pre-treatment tumor marker is a predictor of after lenvatinib therapy. And in Weber group, pre-treatment AFP as well as RB score is associated with overall survival, indicating pre-treatment tumor marker level might be a kind of important prognostic factor. And cutoff of 100 of the pre-treatment AFP level, as well as response, post-treatment response, can stratify the OS and PFS in both groups. In summary, there are no significant difference in OS between groups, but the Weber group showed better PFS, TTL, and duration response, and AFP level and responses may be a surrogate marker for prediction of outcome. So let me make a brief case presentation. Resection after systemic therapy, including 4 cases after lenvatinib and 4 cases after Weber. The macrovascular invasion is a major indicator in this convergent surgery, and 3 cases show the pathological CR achieving drug-free and tumor-free survivor. This is a case of NASH HCC rupture after lenvatinib with 8 months therapy, showing a good response, achieving pathological CR with maintained lower contribution under the control of tumor marker. And this case is HCV with PVTT, showing an up-regulation of tumor marker just prior to resection, despite showing the clinical response, unfortunately, resulting in a very early recurrence. This is a case of Weber and non-benign CLD with HVTT, showing good response, the reduction of tumor marker after 4 months therapy, and achieving pathological CR case, and more than 1.5 tumor-free, drug-free survivor. And this is a case of tumor thrombosis invasion to IVC as well as the atrium. It's a very facing the oncological emergency, and unfortunately resulting in the progression of disease after Weber first line, but followed by lenvatinib with hike with local regional regulation of the radiation successfully, resulting in conspicuous shrinkage of tumor, achieving pathological CR. And this is an overview of our experience. First line Weber and lenvatinib is very effective in response and disease control, like here. And some patients are able to undergo resection. And failure patients are 30% and 20%. We move forward to the second line therapy and still showing a good response and disease control, including the CR cases. And it is important these patients include cases of recurrence after hepatectomy. Maybe it's a kind of, in a broad way, the combination of sequence strategy in the long, prolonged survivor. So now we have to discuss optimal combination strategy to achieve the curative strategy to for tumor-free and drug-free survivor, as well as prolonged survival even after recurrence. And definition of the activity should be precisely defined to offer best clinical strategy to each individual patient. Thank you.
Thank you, Professor Nishio. Any questions? Professor Kodama, please.
Kodama from the Osaka University. Thanks for the nice presentation. So you showed today that PFS is better in atezolizumab compared to the lenvatinib, but OS is not different. So I think that the median observation period should be different, and in the shorter in atezolizumab. Do you think that it affects the result?
Yeah, definitely. And another thing might be the effectiveness of the second line therapy using atezolizumab, I think. Yeah.
And also in the later part, I think you showed very interesting data of the combination of the atezolizumab and the len-atezolizumab sequential therapy. And this progression-free survival, PFS2, looks like similar. Is that correct?
Yeah.
So because this is a discussion in the previous talk, which is better, the sequential therapy, atezolizumab or len-atezolizumab? You showed that today, right? It's the same.
Yeah, but actually, it is depending on the strategy to move forward to the conversion, I think. So maybe considering the good period to response and duration response, maybe atezolizumab first should be best way to.
Thank you.
Professor Tadeishi.
Congratulations for your important presentation. I have one question. We have never seen a complete response confirmed by the resection after lenvatinib. You have shown the several cases of complete response, but it seems that a combination with TSE or HAIC is combined with lenvatinib. Instead, on the other hand, we have several cases with atezolizumab, bevacizumab, confirmed by the CL, confirmed by resection. What do you think about that?
And so the efficacy of lenvatinib and
do you have experience with the complete response after lenvatinib, solely lenvatinib?
Actually, no. Yeah, maybe it's owing to the combination strategy or sequence strategy to achievement of the pathological CR in lenvatinib cases, I think.
Thank you.
Yeah,
Professor Amato, please.
Yes. In that context, just educate me that if you take a breast cancers, they gave the Herceptin as a neoadjuvant, and then maybe almost 70% totally necrotic, and they still do the resection. Now, additionally, like lung cancer, just 2 papers came out in New England Journal. They are saying 1/3 is necrotic. So in the case of the hepatocellular carcinoma, the same line of questions, how much percentage can be necrotic? Almost totally, after giving all those IO or the TKIs and you resect. You can pathologically check the amount of necrosis.
Sorry, I have no data. I'm going to check. Yeah, it's a very important point. Thank you.
Yeah, because the amazing part is the breast cancers, even though they are totally necrotic, but they still do the resections because it's easier. Yeah. Yes. So, okay.
Thank you.
May I have one last question? The criteria to go on to conversion surgery after systemic therapy. There is a criteria for resectability in systemic therapy in naive patients. How about the criteria for those who are already receiving systemic therapy to go on to the R0 conversion surgery? Do you have any kind of a criteria?
Yeah, it's a very, it's still controversial and it's very difficult to say, but resectability should be determined depending on the oncological resectability. And now the conference trying to define the borderline cases, and soon it should be, we have some consensus later. Thank you.
Thank you. Do you have any other question from the floor? During this session, we've learned a lot about lenvatinib, cabo, atezolizumab, its safety and efficacy. And we heard about the last presentation that the criteria for surgery may be improved or progress after the introduction of systemic therapy. And the most important is how to predict the response of these therapies before introducing the therapy. We have a lot of things to do in the future, but in this session, we learned about our present status and the future perspectives. And we'd like to thank all the speakers and audiences who engaged in this important workshop. Thank you very much.
Thank you very much, chairs and lecturers.